of the internal carotid. Further experiences alone can't help. He was always very intelligent, reflecting neurosurgeon, is careful. Then Dr. Gandhi, he started neurosurgery as a general surgeon with Dr. Cushing, and he was more interested to do more. Intracranial arterial aneurysm, always considered rare and almost impossible both of diagnosis and of treatment, are now added to the lengthening line of lesions that are curable by surgery. This was said 1944, 10 years after Ayer. So he's courageous. Even in his time, the angiography was not perfect. And still, he gave an excellent here's Professor Dande and the exploration of a posterior communicating artery and how he clipped this. Very precise. They relate to the oculomotor pulses, and they found that this can be helped. Then he was correct in giving also credit to Dr. Russell. He reported the actual removal of an aneurysm on the anterior cerebral artery operated by Dr. William Cohn in Montreal with an excellent result and, of course, a permanent cure. This is the only extirpation of aneurysm in the literature in anterior antedated our case. You have to look to the publication of Dandy. He gave a precise information what excellent result he had and what problem they had. So I will escape this. Now, what we have are the methods. Extracranial ligature, it was in 1950s also frequently used, say by internal carotid aneurysms or by the posterior communicating. And by anterior communicating, it was an intracranial selective ligature. Then techniques came up, external and internal wrapping, muscle, cotton, muslin, and adhesives. Then internal cord. Hi, Professor. Extracranial ligature, it was in 1950s also frequently used, say by internal carotid aneurysms or by the posterior communicating. And by anterior communicating, it was an intracranial selective ligature. Then techniques came up, external and internal wrapping, muscle, cotton, muslin, and adhesives. Then internal cord, adhesive shear stone, and then Alsne injected iron particle. This was also my idea, stereotactically, to do this. He made it. And then he presented his paper, 1971. Interesting, Electrothrombosis was used by extracranial, not intracranial. 1845 of temporal, superficial temporal artery in 1941. And then bile ejection was used 1963. And then hypercoagulability was introduced, epsilon aminocaproic acid. And this gave also some problem because it made up, if there was a hematoma, they get very tough for surgery. As I mentioned, 1953-65, I have been involved for percutaneous carotid vertebral angiography, and I developed also the opposite side carotid artery to see the collateral system between both carotid system, or by vertebral angiography, I compress the carotid artery, both sides, one after one, to see how the collateral are there. Because the collateral are important for the ligature technique. If the patient didn't have a good collateral, then we could not make a ligature. And I like to tell again here this technique of, sorry, I go back, sorry. So we published 1958, the vertebral basilar system, and here all possible variation was presented. And then 1964, in English edition, cerebral angiography. I would recommend to see this publication just to get a good statistic about what variation on different arteries. But I like to tell that Newton in San Francisco, he published some series of the angiography volumes. In volume 4 is devoted to the brain angiography. There are excellent articles from different authors and very good anatomy, very good anatomy. If you can find, it is a large volume. If we had a special technology with the stereo picture, by, I may go, sorry, back again. Here you see on the back side, the lady stayed there. She moved the cassette manually. We use always 6 cassettes, and then move the camera 5 degrees up and down, or right and left. And so we could make a stereo series, 2 serial angiography, and then see the stereo picture on this apparatus. We could put it from one series, first arterial phase, or later phase, or capillary phase, or the venous phase, and see in the middle of this apparatus a mirror. And you can change the opening related to your eyes and see really 3-dimensional how you like it. You could also move this gun-hole system forwards, backwards, and also this apparatus could be brought nearer or further. And it is very essential to have this apparatus because I was very surprised and impressed as I first time saw this. And you had the feeling you are sitting inside of the brain, and you like this, the arteries belong to you. You saw it all in detail. Our eyes are accustomed on daily life to see, not two-dimensional binocular eyes. They can be also not three. They see always three-dimensional and four-dimensional. Depends what moves. Even five-dimensional. In our daily life, we are using many dimensions. Now, we are surrounded by publication on paper or on the angiograms or on MRI and CT. They are all 2D. To teach our brain, we need 3D, especially for the neurosurgeon. If the neurosurgeon see the structures three-dimensional, four-dimensional, then he can prepare his brain centers for the surgery. He knows where is what, and this is very important. But this apparatus is unique. I have now this apparatus in Zurich in my home, and nobody did like to have it a copy. So it's very pity, I may say. I hope somebody will listen this very well and do something for this multi-dimensional view, what we have in our daily life. If you move your head, it's already multi-dimensional. In doing the studies, I studied also the histology and found some 11, 12 different segments on carotid artery, how they change. They get smaller when they have a different histology. Inside of intracranial, there are no vasa vasorum. So outer layer of the adventitia is supplied by CSF. It is very essential. Then we studied the collateral system and realized the brain arteries are not end arteries. They have a good connections between same ipsilateral, but through the basal circle, they have connections right and left. And this collateral system is interesting because functionally we are not able to control the quality, how good they are. It is said the children have a better collateral system, but we see this doesn't work always. Some elder people have also said very good collateral system. So what is behind this for me is not clear. And we are still nowadays not able to study the functionality of the collateral system, which is eminent for indication for surgeries. And we have to work on this. This is a message on young generation. Think on this the collateral system, how reliable they are in given case. We are just guessing. He may have a good or not. Now, another point is perforators. There are regular systems, but some variation also. I put this all variation in the volume 1. And important is the perforated from anterior communicating, and also from P1 and also superior cerebellar artery, all others. And also the variation from anterior spinal artery is very interesting. We put this also in the volume 1. We have to know and respect these arteries because they are end arteries. Very rarely they can be changed by AVN cases. Studying the literature, I came to this publication. Is an excellent embryonal development of the arterial venous system, published in a book, Embryology. It is the ontogenesis, the phylogenesis. I didn't see any good book. Maybe there are, but I didn't know. And then here, in 9 months, the transformation of the arterial system is impressive. This runs genetically, sure, and finally ahead of its individual architecture. Now, who made these pictures? This is Lady Hager painted. I forget where she is in the United States, and her father was a teacher, and he discovered that she's very talented on drawing, and sent her to New York to art school, but she got somewhere message, hey, somebody does very well studies on brain vessels, and he went to Max Brodel in Johns Hopkins, and they developed all the publication from Cushing, Dandy, and all other chairmen in other disciplines. And she died in early age from cancer, but she published 1948 the embryology book. You should find and study this book. Very respectable. She didn't get any doctor and professor title, nothing. For me, 1962 changed the entire my career. Is this Professor Ake Senning from Stockholm were chosen as a chairman in Zurich surgery department. He is a very great, talented man and also engineer. He created himself an extracorporeal blood exchanger machine and brought this also. Then he started to perform open heart surgery. In one 17-year-old girl, she awake with a hemiplegia and aphasia, right side. I made an angiography and found, as you see on arrow, an artery. This is a central sulcus artery giving branches to the precentral and postcentral. And I showed the picture to him and he said, hey, you like to operate cardiac. This is our field. This is your field. You have to learn to do this. You must operate now this girl. I said, I cannot do it. It is I have no experience. I have no microscope. I have no suture material, fine suture material. But by his insistence, I had to go to learn a new world. What happened? It took us a while until we found who has a laboratory. Dr. Pierre Donahue in Wellington, Vermont was the chairman of neurosurgery, but he was interested to do also vascular surgery. And in the same department was appointed Julius Jacobson, from New York, this cardiovascular surgeon, and he became a worked for a pharma country to study the carotid artery and transect the carotid and suture it again. And then his assistant Suarez from Argentina saw in laboratory OPMI-1 first operating microscope. And he asked him, we should take this, and he took it. And then he said to me, I met him in April 1966 in Mount Sinai Hospital. And he said, it's like with telescope, you look to the moon surface. It's different world. He's right. If you look through the microscope, it is another world. You are suddenly inside of the brain, you see 5 times or 10 times or 16 times or more increase size of the structure. In the end, Dr. Danahis was impressed what he's doing. He started also. And then same time, interesting thought, Dr. Harry Bunke was a cosmetic surgeon, plastic surgeon in San Francisco. He started himself to do this under microscope with OPMI-1. And I visited him and was very impressed. He showed me in a cage that, you see, this monkey, in this case, we succeeded. We made a free transplant from thumb to the big toe. It works. These are very small arteries. And unfortunately, we lost Harry Bunke on a motorcycle accident. He was a great man. So Dr. Dani was doing this surgery. In laboratory, he was interested to work on carotid artery on rabbits, and he used to make a fenestration on the artery. It was difficult surgery to anterior and posterior sides. So I made this, I learned this. And then he spent one morning with me. And then my main teacher was Mrs. Jackie, Mrs. Roberts. She was head scrub nurse. And she was very patientful and very strong and followed what I am doing very well on an observer and helpful on. She was informed about the techniques. Coming to the microscope, I like to tell also to you this gentleman in Netherlands, Holland, Leeuwenhoek. He was a businessman, wealthy, and then was very interested on the biology and developed a new technique hidden, prepared from glass, any objective. He melted glass and the drops of the glass with the small objectives. He could see with this method three or 300 times more magnifying. He saw arteries on the erythrocytes. He saw the brain cells. He saw spermine moving. And he impressed with his lectures, and he was selected, elected to the Royal Society in London. So a very respected person, but nobody followed him. Here is another gentleman in Rome, Giuseppe Campani. He published 1686 a book in Leipzig with this 6 tables. This table shows this microscope is same time a telescope. You can look to the sky, or you can look to the wand to see better. He wrote a letter to Pope saying, this is really a future and we should support this. And you see, at that time they gave light by candlelight. Now we have a perfect light. This is the story, but it took another 300 years until Olaf Nyland in Stockholm used this microscope was fixed on the operating table, and we had a good correspondence. And she sent me these pictures. He operated autosclerosis in 1920s. So the A.N.I people in 1930s, the ophthalmologist. In the 1950s, the neurosurgeon. And here I'd like to show you a story. And this Dr. Littman is an engineer by Zeiss company in Oberkochen, West Germany. And then here is a Professor Ulstein. He was ENT professor in Würzburg. He made it some 1,000 and more operation autosclerosis. And Dr. House from Los Angeles came and saw him, returned to United States, and he started to operate with his assistant neurosurgeon, schwannoma, with other lesions. And this was not naturally irritating. We ENT surgeons operate now acoustic similar schwannomas. The history is this way, there's nowhere written. Now, you see here in the middle the microscope, what was used for in Stockholm first, and then the right on the corner is the one. But I found it is excellent. I used it 5 years, but we need more mobility because it's not heavy mobility, just millimeter-wise, a little from the right side, a little more from anterior, posterior, and then so we developed this system with counterbalance technique, and was with a good brake system, and then important, I forget to publish this. You see here the objective of the microscope. Behind the objective, there are two small objectives. The distance between both is only 16 millimeter. The Zeiss people told me, if you like it, we can go down to 6 millimeters. I no, this is enough. This means you can see stereoscopic by 16 millimeter opening. The magnifying glass, they have a 40 millimeter, so they cannot see stereoscopic. And all other colleagues, if they don't retract strongly more than 4 centimeters, they don't see stereoscopically. They see monoscopically. And this is the point where we're different. But I had to learn this. We developed also this hydraulic chair, and then here armrest. Armrest is very important because while surgeries, we can stay 10 minutes, 15 minutes in the air. But mostly we are holding the hands over the head of the patient, but it is not good mobility. So we made this system, and it was made first in Zurich, but the company could not produce more on good one. And now in Istanbul, somebody made this. It's available now. It is 360-degree mobile, and up and down. You can move it. I will show you on movie how it works. So with one movement, you can go up and down with it on your chair and your armrest and our mouse switch. You can move the microscope. We need for work different size instrument. On the surface short, and then deeper and deeper. Sometimes we have to go 10, 12 centimeter. And for this, we made a series of forceps. Now, we have to buy this series, not because I don't get any profits, because if we need them. They have 4 different tip size. They could be even 10 different, like by watchmakers. But it is good for some 30 forceps. Will be useful. Now, aneurysms surgery. Under the operating microscope, Adam Witt operated 1964. And Pool 66, there are single cases on the microscope, but they never been trained in microtechniques. Rand and Janet, they showed me one case. As I remember, was a basilar bifurcation. The last, the microtechnique, if we are able to follow the cisterns, and because the arteries and veins are in the cistern, they look on the surface, but they're mostly intrasulcal. And then we have to control the hemodynamics with, if necessary, temporary clips application proximal and distal to the main artery. And I had a concept 3 minutes, not longer. But it happened, it was 4 minutes. And because from physiology, I did not complete stop of the blood supply or brain tissue. After 3 minutes, they start to die. So it was 3 minutes fixed. Then important is to have a bipolar coagulation with many forceps types. And then it is not just clipping of aneurysm. I will show you why. We have to coagulate and shrink and create a neck, because most of they don't have any proper neck. They have bulging part. And originally, as I coagulated down, I used only 6 clips, 6 type. But there are now 100 or 200 type clips. Then we can make an extra intracranial bypass, but also intracranial bypasses. And we can also remove the sclerotic part of aneurysm and then cut out and repair by suture technique. And then we have microdoppler flowmetry. This is very important. Sharper had developed also transcranial flowmetry, which is very important. And then with endoscopic techniques, we can show around the corner. I had a mobile mirror, but endoscopy is much important. The picture is not good. It shows some of the clips what I removed, I used, and we develop also very small for the perforating arteries or the AVM cases, small. Important is to have a well-controlled suction pressure. With this, operating nurses scrap nurse, they call in English. I said, please higher suction or lower on it. There's an expert nurse. They know how much we need, and they control just squeezing down or opening, and then the end of the suction tube. We put these pieces and this. Enjoyed also Dr. Rotten, he put also in his system. Important are these sponges are very soft, high quality, in different size, and with the leg size tail. In United States, we had to put a piece of a metal post-operative. We controlled the number of the use, but still there was a control to see whether something forgotten and overseen. Now, by paternal craniotomy, we open this way, a little frontal and then a little temporal. It's a small craniotomy. Originally, I used 4 barrel. Later on, I used on 1. And then this happened. This is why I'm showing this to you. In some cases, I don't have numbers, but maybe 1% or so can happen. The superior Sylvian vein, proximal Sylvian vein, can enter into the dura here. If you cut it here, then you get a big problem. Maybe they have a cholesterol, nothing happened, but it is better to, in these cases, coming here, cutting the dura, look underneath, turn around, the dura show whether the vein enter early. This happened. And then in these cases, open on the frontal side and also temporal side, and you can work on from both sides. These are small tricks. Now, aneurysm, they can be each size, they can be, they may have a small baby aneurysm, but the important is they never, my knowledge, never ruptured from the base. They're always in this corners or baby aneurysms. The heteromorphy of this wall is very, very individual. And we have to know this area is different. And important is for us aneurysm. We say medial cerebral aneurysm. They can be inferiorly directed or superiorly directed. This is a posterior directed. Sorry. Posteriorly directed, superiorly, and inferiorly, all mixed. On angiogram, we can study it. In which direction? It's very important because you cannot come in this case and follow the M1 around. If you try this, then you have trouble. And sometimes this may be attached to the dura. And so we have to know the direction. And then also the relation to the cisternal system. K1 Ratius, 1875, they describe the craniospinal cisternal system perfectly. 2 big volumes. And I learned from this publication, and also I put my view how they are organized in compartments. And there are many different compartments around the nerves and the arteries. And the point is here. If you like to go by picture, I'm not describing the cranial, you can look on the volume 1. The single fissure can be, did I make something wrong? Yeah. In some 5% very easily open. And you can go just this 3-4 centimeter within 10 minutes. But here is excellent. Here needs time. Because there is one surface of membrane, arachnoidal, with a knife we have to cut. And the M1, M2 are inside. When they are not free, they are full of very fine arachnoidal fibers. Now, in this situation, it needs time. Now, this opening some 3 to 5-6 centimeter distances require patience, time. And I am very sorry to say, I tried to teach again, but I have only not more than 5-4 colleagues. They are able to open the single fissure properly. You can see now by ultrasound detectors whether any damages around happen. It's been controlled also by MRI. It should be nothing injured, also no vein should be injured. You will see, I will show you a video you can follow. But for this we need different sizes instrument. You cannot have a tree type. Sorry. Now look here. This surface, and then this, we save this part, and they can mobilize this part a little to come in, like here, M1. And now, I opened at least 3,000-4,000 times single fissure. But you will see on my movie, I separate with the forceps. My forceps are not soft, they are a little strong. You can separate this way. Spreading movement. And I came here 7 years ago, and Dr. Smith spent with us some 5 years. And he developed his own views and concepts and instruments. He introduced this scissor. You know, if we have a straight end of the scissor, we don't see the end where we should cut. So therefore I use 2 forceps to come down. Now you will see Professor work with scissor, and this is much superior. It is a one-step advance. It doesn't use this spreading, it uses this very special scissor. These are made also here in Istanbul. Other companies, they didn't like to do this. Now you see how I'm opening carefully first Sylvian fissure, and then down to the chiasmatic cistern. Yellow color, you see the olfactory, and then I am following the A1. And here, after opening, you see if it's like a nice street down, and this is retraction. This is just a support, because with the instrument, with the fast movement, you can injure the pia. So this is the view. This is just not more than 2 centimeters.
Yeah, gracias.
You have control enormous area, ipsilateral, also contralateral, and down to the basilar. And here, in some cases, the olfactory can be short. Then you have to mobilize, take anteriorly to come down, unless this will rupture. Here, at the beginning, there are many compartments: proximal cilium, and then carotid, and the olfactory, chiasmatic, and posterior communicating anterior girdle. They have different compartments. Here, on the left side, you see how the brain look like. If you like to come in without opening or sealing fissure, you have to retract more. But if you open it, it's in front of you. Now, to the vessel, you will see more in volume 1. We may have a junction or acigal situation, very rare, 1%. But usually we have this 2A1 and 2A2. And there are an enormous variation of foraminas, or 2 anterior communicating. And then third A2. And this has been already before described, but we found a little more. You see on this picture, asymmetrical. Right side, normal. In the middle one, and on the left side is only frontal area. Here is mirror. There is a 1/3 A2 vascularizing both sides. So if you would put an aneurysm around the corner here, and then you clip this artery, it's not good, because we have to save the anterior communicating perforators. These are the main important part of the hypothalamus and anterior commissure. We have to save them. And there are some more variations. You have to look. We have to pay attention to this. Now, you see, on angiography, you see an aneurysm of anterior communicating artery. But if you have a stereoangiography, you see a little better. But here, after my dissection the area, look how complicated. Double anterior communicating, 3A2, and where the aneurysm arises. That's it. The neuroanatomy is very important, neurovascular anatomy. Now here, variation, anteriorly turned, anterior communicating aneurysm, superior, posterior, and inferior, and the combined type. Now, if the neuroartery is described anterior, it is so. For a little 90-degree different. So we have to know. Now, very important part. Anterior communicating. A1, A1, A2, A2 aneurysm. And then behind are the perforators. If you look this way, cut it, there are always in the inferior of our aneurysm bulging parts. Like here. If you clip this way, then this remain. Or you cannot separate well perforators, you will say, I put it here and then put a little muscle. But what happens here? I operated some 2,200 patients on aneurysm with 3,000 aneurysms. But I suffer still, sometimes even day and night time. I forget all the cases who had a good outcome. But on 6 patients, they started to bleed again after 2 or 3 months. In 4 of them, I lost. It's my failure. We should make a complete elimination. We can make it stepwise. You see here, naturally temporary clips, 2 or 3, 4, and then turn the rest of aneurysm around the corner and see what is bulging backside. I will show you this on a movie. And this is very essential. We should not leave any part. The aneurysm should be completely eliminated, not just put. Even in elder, if you put 1 clip sometime, it's okay, but you can see still voluminous, put the second one, and put the third one, fourth one, and then it should collapse a little, just soft, then you can puncture and cut it and remove it, what you like it. And here, you see, after right side, after I resected this large aneurysm and coagulated down, this is within 10 minutes, and the final clips. And the perforator you see down there. You will see on movie a case after communicating how I had to coagulate properly to catch all part of the aneurysm. Now, I'm coming soon to it. This young girl in age 5 came with problems, not paratic, but she had a more bulbar symptomatology. And the study showed from the left vertebral artery a large aneurysm this size. You see on the right side on the drawing is a large aneurysm, and interestingly, the perforator are arising not from the aneurysm. The aneurysm segment display the entire artery, so we can use the trapping technique. Now, you can also make a graft between inferior and superior part of the basilar, but I couldn't do it. Maybe young generation will do it. What I made it trapping. You see? The superior part of basilar gets from posterior communicating, and inferior part, right, but the left side is clipped, as this girl. So you can trap. This is possible. I made 8 cases on this one. And this lady came to us just by airplane, brought the Elton to us from Italy. And in the parade, she had all the tracheotomy. had a big problems respiratory. The angiography showed a large aneurysm, much larger than the partial thrombose. On her case, I also used the strapping technique in one session. By girl, in 3 days. And you can see it's filling from the cardiac down in the one side from vertebral. And she recovered full. And you see here, it's tracheotomy area. It was a learning piano by a famous pianist in Italy. And she finished. And it happened, this picture is 1 year later. She came for a internal meeting. We invited Professor Nornes from Sweden. He was a famous aneurysm surgeon. And she played us in a restaurant, in a piano, Debussy for 1.5 hours, non-stop. It's fantastic. And everybody was out of pleasure. Now, this was the good. Now, I'll show you for the young generation, Dr. Krish. Look here. We see an aneurysm on the anterior communicating. The patient was some 30-year-old young man, and he had one subarachnoid of hemorrhage. I explored him, and I made this picture. You see the A1s in the middle, a flat aneurysm type, but I didn't know what to do. And I put a little muscle around, over and underneath, around, and hoped. And after surgery, after the patient was awake, some 1-2 hours later, I visited him in intensive unit. I told him we explored, but I make a drawing. I couldn't clip. He started to cry. He said, "Professor, I came to you. You will rescue me. You can be sure I'm going to die." I didn't know what to do. Even today, I don't know how to manage this aneurysm. These are the A2s going out and the A1s. And I'm thinking, today, because the perforator are behind, I couldn't do it. Believe or not, he died on a next bleeding few months later. You see, I suffer on this. Now, we show you a movie on operating room. Mr. Ali made this, my hydraulic chair, and how I am working with my hydraulic arm rest, and how the system working. Now, watch now. This is the way how I made it. This round knife is used by ophthalmologists. We said, make a joke, said this is an Eskimo knife. It's got some 300 degree. You see, we open the membrane, now we are coming down. You see, on the middle cerebral artery and the bifurcation, there's a bleb. He has everywhere small blebs. So after my observation of 3,000 aneurysms, I was convinced it is not the atherosclerosis, the weakness of the wall. It is for me the infection. Something happened to arteries maybe weakness. You see, here is the aneurysm. Here, another aneurysm on the internal medial cerebrum, proximal medial cerebrum, and then also in the anterior corridor here and posterior communicating. You see everywhere small blebs. Now I'm opening over the chiasmatic cistern. I left the area with the aneurysm untouched. I'm going to the left side. Now, Professor Ture used scissor, his special scissor. We are on the left side. I clipped only one case, both side internal carotid aneurysm on the bifurcation, in one case posterior communicating, in one case also the proximal media opposite side. Here, the opposite side. Now I'm coming back to ipsilateral. Still dissecting the area. In the case, if something happened, I need to clip both carotid. Here is the aneurysm. Here. And here's another aneurysm at the origin of anterior corridor. Here's the base of aneurysm. I'm looking where the Heubner artery is behind it. So I put the first initial clip. Watch now what will happen. So I like to dissect to see whether there is a Heubner artery behind the aneurysm. I started to coagulate. Here I was not careful. It starts to bleed. So it's not completely clipped. But to have the bipolar is important now. Second clip would be more dangerous for the Heubner. So the aneurysm seems to be completely eliminated, but watch now. I'm coagulating now these small blebs. Dr. Tiddy told me this term bleb from Oxford. Anterior posterior communicating. Now I can put now the clip, temporary clip over the area where the aneurysm was. Anterior corridor. So to be sure. So, what's now? Still, he has a good collateral. It feels. What's now? Is he on the backside? There is a bulging part. It is pity we don't have a smaller head for this clip. But physically, it doesn't work. Smaller head. That's it. I put over these small aneurysm areas pieces of sponge to make a small inflammation. Now, the second case is with the anterior communicating aneurysm. It was more challenging to open properly because it was more close. You see, I'm opening with the forceps. Two forceps. So, if you are at home with the cysternal system, then you have better judgment. At the beginning, you know it is strong, you have pull a little or a little more. So it is a feeling. Why I couldn't I use scissor, but as you don't see the end of the scissor, you could cut an artery or vein, mostly vein, and this will be not good. So with Professor Tiller worked with this special scissor. The M1 segment can be sometimes not only 1 centimeter in depth, can be 3, even more centimeter depth. It depends from the volume of the temporal and frontal lobe. Very individual. So, as a surgeon, or even you as an observer, you are inside of the brain. You see, you are in the brain. And we don't sacrifice any vein. You see, all these veins remains. We go around, we mobilize them. Nothing will happen if we sacrifice. But better, don't be aggressive. We have no right. From inside out. I'm funny in my association. I think to the orange slides. You can better open half or then from inside outside. Not all the slides from outside in. It is not possible. Same here. You see, I entered some place, now I'm going down from inside out.
Gracias.
I may confess, really, I never injured with the tip of the forceps any artery or vein. I don't like to say, hey, I'm good. I'm happy. My brain and hands work very well together. You develop for this fine feeling, like the people who, after long exercises, they can play violin or piano perfectly, and I am admiring to see their finger movements. Incredible how they touch quickly. Same, you must feel this. Is a dialogue with the tissue of the patient.
Por nuestros servicios su primera consulta.
You see, the sponges are very helpful.
Por nuestros servicios su primera consulta.
Sí.
They suck the fluid.
Ya, señor, doctor. Yo hace aproximadamente 2 años
Sí.
We are coming down.
en un bus. Me caí y me golpeé la cabeza.
It takes time. It takes some time, believe me, 1 hour for this distance or more. Especially in cases they didn't have any bleeding or tumors, but the patients with the hypocampal sclerosis. I operated some 220 cases, half in Zurich, half in the United States. In these cases, it must be some meningitis happening. It's much more sticky. It's very difficult. It needs sometimes, believe me, 90 minutes to open this area. Natural, not everybody has that much time. But if we don't do very good work, we spend later on more time because we made some mistakes.
La estructura cerebral se ve mucho mejor, con muchos detalles con el tema de la tomografía.
I am still not by carotid.
No siento molestias, ¿no?
Pero quiere estar segura usted que pueden traer consecuencias y la única forma de estar seguro es
que on the carotid system.
La imagen, hay dos, ¿no? O tomografía o resonancia. Lo más sencillo cuando no hay síntomas es mejor tener una tomografía y con eso tenemos mucha certeza. Lo hacen aquí en el hospital, se puede hacer una, lo hacen ahora y antes de que nos vayamos lo vamos a volver a ver si es que estamos por aquí. También aquí estamos a la 1, ¿está bien?
Ya. Dependiendo cuándo puede ser.
Creo que no está tan caro. Aquí está mucho más barato que en la calle. En la calle es más caro estos exámenes.
Una tomografía, ¿no?
Sí, sin contraste.
¿Cuál es la diferencia de contraste y sin contraste?
Cuando uno sospecha de algún tumor o aneurisma, ahí pensamos en tomografía. Cuando es consecuencia de un golpe, preferimos que sea solamente sin contraste. Este está orden para que la puedan hacer y con eso la puedan evaluar ahora mismo. ¿Cómo no? Sí, en el tiempo que sea posible. De todos modos, yo estoy aquí los martes y sábados para poder verla y poder evaluarla. ¿Sí? Pero ahora puede averiguarlo justo con la señorita para que la guíe. Y ya Si de repente sale inmediato y lo vemos
I
también.
hope I mentioned the
Esto se llama Grace. ¿Cómo no?
importance of the teamwork, perfect anesthesia, and perfect nurses, scrubs, and technicians. It is a teamwork. The patient should not awake and should not have a seizures. Can you see by this sensitive procedure that the patient gets seizures and the head starts to bleed, although the head is very fixed still, it moves. I forget to mention, from the frontopolar arteries at the base, there are in some cases smallest arteries going to the dura of tuberculosis between two optic nerves. Now we are by carotid. I use scissor. Here I see the end.
Un asiento, por favor. Ah, sí, no le cierre, por favor. Un segundo, ya la señora que está ahí.
This is original movie. I didn't cut it. It's to make short. Now we are going over the midline to the left side.
Luis González, ¿no? Yo.
Now we see optic nerve and olfactory.
¿Quién le puede ayudar? Dígame. Doctor, trabajo manejando, ¿ya? Conduce usted.
One point I forget to tell is very essential. During surgery, we give to the patients per hour 50 milliliter
Súbito eso
fluid.
empieza o empieza
Not
o a
more.
veces
We don't
puede
take
tener movimientos y fastidio.
1 2 liter now. Few, because imagine in the morning everybody drinks 1 cup of tea or coffee and stay well until 10 o'clock or 12. We don't need that much fluid if we are not living in this warm areas. So the patient don't need in visiting some other centers. I was surprised. The patient did, before the surgery began, they get fluid.
Cuando cierras los ojos, acabo de verlo, tienes esa misma vena encima de los dos párpados, incluso.
Our concept is here.
Tu párpado vibra muy fácil, está vibrando, incluso.
Normal
Si
volume,
no si estarás sintiendo
not
que no,
hyper
pero
volume.
yo lo podría evidenciar cuando cierras los ojos. Te explico.
Now we are over the optic.
Cuando está bajo un fenómeno de tensión o estrés, como le llamamos, suelta adrenalina. Es nuestra forma de defendernos. El cuerpo suelta adrenalina.
We are over chiasma.
Dosis bajitas pero constantes. ¿Okay? La adrenalina hace que nuestros músculos se contraigan, se pongan duros, se pongan tensos.
This patient
Lo
did
que
not
pasa
have
es que
any
los
bleeding.
músculos más delgados,
His symptom was
los que son más delgaditos,
headaches.
lo que va a producir
And
no
then
es que se pongan duros, sino que va a producir
some
que
weight,
estén
I know.
temblando,
You see the
estén
small arteries
vibrando.
going to the
Músculos más pequeños son los de
dura
las
of
manos, de los deditos, y
to
los de los
the
brazos,
dorsal
porque
area
son músculos bien delgados
there
que tratan
behind.
de manejar cosas finas. Entonces, bajo un estado de
You see this
de
artery?
tensión, esas zonas se van a mostrar más
If you
y el niño
pull
va a empezar a percibirlo. ¿No?
and
De
rupture
repente lo
from
de tus
the
manos puede ser que
main
no
artery,
empieces a
you
percibir
may
como
have
que hay un pequeño
a
temblor
feeling in
cuando
the
sientas
bleeding
hacer algo
from
con mucha
aneurysm.
delicadeza. Puedes
Is
haber algo por el
bleeding
temblor.
now.
Pero lo de tus ojos tú lo vas a ver porque tú trabajas
Not
con
every
eso.
case, but
Cuando tú
some
trabajas
cases
con
I
eso,
saw
empiezas a
this
notar que hay algo que está vibrando. Esto es un fenómeno
also
de
by
estrés que
interhemispheric
está bien.
approach from
De
colors of
repente sea tu
marginal
trabajo, de repente sea
and
alguna otra
pellicles, so there are
situación.
branches
Pero
to the
no es normal.
faults.
¿Ya? Es manejable, lo que hay que hacer es, así es, lo que hay que hacer es hacer que descanse bien tu cuerpo en las noches. Para eso te voy a dar unos medicamentos que son relajantes musculares, para que descanse mejor tu cuerpo en las noches y al despertar un poco estés con menos de esta tensión. Ahora, es importante
I'm using scissor.
que de repente encuentres durante
I
la
see here
semana
the
de tu
end,
trabajo,
okay.
encuentres momentos de
Now the
liberación de
opposite of
tratar de desconectarte
optic
un poco
nerve.
del trabajo, del diario, de lo que normalmente haces de repente durante el trabajo. Después de 3 horas de trabajar seguido, de repente te puedes regalar unos 10 minutos o 15 minutos de desconexión, ¿no? De repente se desconecta el celular, te desconectas del ambiente. Tratar de que salga a tu cabeza y liberes tensión. La idea es liberar tensión. Es la recomendación para todos los que trabajan 2-3 horas de trabajo, hay que tener 15 minutos de liberar tensión. Y de cada semana por lo menos un día de liberar tensión, porque es tensión acumulada y el cuerpo acumula. Entonces empieza a hacerse más fastidioso los síntomas. ¿Ya? Felizmente es manejable, felizmente no es grave. Lo que hay que hacer es dar relajantes musculares para que pueda descansar bien.
Now the opposite internal
Poco
gravity.
a poco iré entiendo. De repente, claro, hoy no podemos saber cuál es el origen de la tensión. De repente es tu trabajo, la mayoría de veces es el trabajo. Pero también estamos todos para el trabajo en esta etapa de tensión natural, que estamos obligados a estar bajo restricciones, que no es normal. Al menos no para las personas jóvenes, no es normal. Pero ayer me contaron
This is the A1 left side. And you observe also the importance of the small pedis. They're soft.
Ya, ahora trata de sonreír como quien le pareja así, mostrando los dientes. Ya, ahora cierra los ojos, poco fuerte, como si estuviera haciendo fuerza. Ya.
Safety tissue.
De repente sí es un proceso de adormecimiento que vas a tener en uno de los medios de la cara. Ya, pero me muestra la fuerza de los ojitos, eso me vale un nervio, y el poder retraer la parte de la boca hacia los costados también me muestra que el otro nervio está
The
bien.
arachnoid system
No es parálisis facial, no
should
está
be
presentando. Ya, vamos a trabajar algo relajante,
studied under microscope
pero sí, como te digo,
from
como
surgical
tienes que encontrar
perspective.
momentos de liberación de tensión para que no se acumule mucho. ¿Ya?
I applied this from my surgical experiences
Creo que son
and in my
momentos
imagination.
que son como neuropatías.
But
Es
it
como
should
que
be done
lo que decimos, no sufrir de
anatomically.
los nervios, ¿no? Entonces,
You see both
si no
A1.
mejora solamente con relajantes, hay que empezar a tomar vitamina B, que es para los nervios. ¿Ya? Te lo receto, te lo puedes comprar, pero sobre todo yo quiero trabajar con los relajantes, que me parece que por ahí va a ir mejor la cosa. Claro, eso tiene razón en esa parte de no dormir en mis horas.
I'm retracting the brain with suction tube. It is at the moment very low suction pressure.
¿Cuántas horas seguidas trabajas al día? 8, 9. ¿Y todas conduciendo? Sí.
The brain is like our skin. We can touch it and compress, but not continuous the same point. Then it's a problem. But you can just, like here, I can push a little away. There's nothing happening. Also the arteries, they don't get spastic. If you squeeze, then they will be.
¿Ok? Todas las noches, por lo menos media hora antes de dormir, calcular el dormir más o menos entre 11 de la noche, es un buen promedio. Para tratar de que duerma usted 6 horas por lo menos continuas y puede estar al día siguiente mucho más recuperado.
Now we are coming to the corner where aneurysm is.
Que todavía hay síntomas, viene para de repente modificar un tratamiento adicional. ¿Ya? Listo, eso es todo. Buenas tardes. Hasta luego.
Del señor quiero de su mamá, de la plaza.
Here I saw the perforator underneath of anterior communicating, but I don't see here. Here, it's just small one, running backwards. I like to open the lamina terminalis. This helped us to avoid the development of hydrocephalus. Before we had some more than 10% hydrocephalus. Temporary clip to A1. And after opening lamina terminalis, it came down to 3%. Another black tear. Aneurysm is more inferior returned. Is extend under the A2 left laterally.
No ha tenido atenciones previas por nosotros, ¿no?
No, we got the base of aneurysm. But
Dígame, ¿qué le puedo
it's
ayudar?
inferiorly bulging.
Ellos es una persona que por la edad estaba muy bien, pero como este tema de la pandemia era muy activa y bueno, quedarse en la casa y todo parece que ha tenido sus efectos.
Okay.
Entre otros, está teniendo problemas para teniendo que tener unos dolores un poco a lado izquierdo.
This is the first clip, initial clip.
Era un video constante en la mano izquierda.
Ya. O sea, más para este lado, que vino el
Más que todo es la pierna. Después ya las piernas ahora con el tiempo ya no tiene fuerzas para caminar, a veces también tiene dolores en los dos brazos, ya el dolor un poco más generalizado, ¿no? Aparte de unos problemas gastrointestinales que
So the removal of the temporary clip.
Pudimos ver una consulta y tomar una tomografía de cerebro y
Again applying.
Se hizo todo el perfil lipídico
After
perfecto,
a few minutes,
glucosa perfecta, se hizo una vitamina B12,
see what we
está
can do
en
more.
medio de los valores,
There is more
pero hacia
aneurysm
abajo.
there.
Es aceptable.
Claro, entonces, ¿cómo comenzó a tomar algunos analgésicos? Se le achacó al estrés, tomó un poco de
It's a bulging part.
fertilizante, un poco más de vitamina B, pero no pasa. Entonces, se le hizo una radiografía ahora de lo que es cervical y despacho.
Lo que no pasa que es esto, Perón, o qué es lo que más
Claro, vienen los dolores un poco más acentuados, no se le ha ido del todo el hormigueo, y la pasada se levantó y ya
In
no
this
tenía
case,
fuerza en una
the
pierna.
perforators are more
Entonces,
on the right side, down perpendicular.
al día siguiente mejoró un poco y
I may show you
está
later.
tratando de caminar unos pasos para no estar inmovilizado. Y ya pasa la mayor parte del tiempo en la sala sentada.
Now this is real feeling and experience of a surgeon, how much he can play around this corner this way. Push and pull.
Y estaba llevando, trayendo, entonces
Now what's
era
what
un
I'm doing?
resultado, era un informe, un CD.
Bien.
Y el informe que me preocupó,
I'm
pues no
pulling
sé
a little
pero me preocupó porque dice unos pensamientos o en las vértebras C5, C6,
Okay.
C7, algo así. Entonces, eso podría estar, según lo que pienso, afectando y necesitaría ya otro tratamiento, ¿no? Pero estamos seguros mientras no hubiera resultados.
Pay attention until communicating with the perforators.
Estas son las
This popular application.
ya, y desgraciadamente, doctor, de la radiografía última, solo tengo civil también.
For a moment, here, the perforated. They go here, you see? These are the perforated. You see?
Okay.
Algunos lo tienen al lado derecho.
Sí, este no tiene para ver CD, ¿no? Sí.
Thank you, Professor Yasargil.
Sí, perdón.
A ver, ese pensamiento de los espacios C5, C6, C6, C7 con esclerosis de sus superficies. Conserva la curvatura.
Okay, this brings us to the conclusion of our session,
Vamos a ver si es necesario que
and
solo te vas a dedicar a radiografía sonora.
Professor Yasargil has also been working on the next seminars that we have. We're planning them in the next couple of weeks. We will make the announcements with Dr. Aboud. He will be sending us the announcement. Also, this lecture will be posted on the Arkansas Neuroscience Institute channel on YouTube. So thank you for everybody who has attended, and I hope this was educational to a lot of you. And we will hopefully see you in the next seminars.
Eso el migueo es, entre otras cosas, lo que nos preocupaba por
Le cuento un poco, me parece, lo que le explico un poco. Nosotros, todas las personas, con los años, a partir de los 35, padecemos de una enfermedad que se llama artrosis. Todos, ¿no? 100% de las personas, todos los humanos. Esta enfermedad se trata básicamente de desgaste. Nuestro cuerpo se desgasta. Entonces, es natural que se desgaste, sí. Todos tenemos que desgastarnos. ¿En qué lugares se desgasta? En los lugares más móviles del cuerpo. Hombros, caderas, rodillas. Muñecas no tanto porque como que no carga mucho peso, la mano no pesa mucho. Hombros, caderas, rodillas, columna lumbar, columna cervical y columna lumbar. Son las zonas que más se gastan. Son las zonas que más soportan, o que más trabajan. Entonces, vamos a enfocarnos en la columna. La columna tiene sus etapas, ¿ok? Entre la primera etapa, los huesos no se afectan. Se afectan solamente los discos, que son nuestros soportes en nuestras vértebras. Ahí es donde vienen las hernias, donde las personas se preocupan de tener hernias. Y usualmente esto pasa entre los 35 hasta los 55 años. A partir de los 55 ya es como que si hubieran ya gastado lo suficiente los discos, que pasa a una etapa de gastarse ya también los huesos. Y entonces los huesos, que son una especie de cuadrados, nuestras vértebras, en realidad son como un cilindro cada vértebra. Pero si uno los ve en exámenes, se ve como un cuadradito. La superficie superior y la superficie inferior son las que primero se gastan. ¿Ok? Entonces, eso sucede hasta los 65 más o menos. A partir de los 65 en adelante, 75, la columna vertebral de lo que normalmente tiene un cilindro, otro cilindro, otro cilindro, otro cilindro, pero protegen un canal. En el medio de toda la columna vertebral hay un canalito donde pasa la médula espinal. A partir de los 65, 75, la afectación del hueso empieza a generar estrechez del paso de la médula espinal. Entonces, ¿qué pasa con nuestro cuerpo que empieza a los 75 empieza a encorvarse, ¿no? ¿Por qué? Porque quiere ganar espacio, porque el espacio se lo está quitando los huesos en su desgaste natural. Entonces ese espacio empieza a hacer que nosotros nos encorvemos. ¿Por qué nos encorvamos? Porque nos desgastamos y porque queremos espacio.
Y está encorvada, ¿verdad?
Entonces, es natural que las personas se empiecen a encorvar a partir de los 75, 70 y en adelante.
Eso le ha pasado a ella.
Entonces, lo que diagnostica aquí, pinzamiento y esclerosis de superficies en 3 vértebras, que son 5, 6 y 7, es natural que lo tenga. Si cualquier persona de 70 años va a tener eso, lo más probable es que sí. Los pinzamientos, ¿qué significan? Aplastamiento de los discos, que naturalmente se han gastado hasta los 50, 55, ¿sí? Entonces es natural. No me preocupa mucho eso. Ahora, ¿qué le voy a decir que sí me preocupa ahí? Le voy a decir nada. Existe que el estado de estrechez de la médula espinal, que es lo que genera nuestro encorvamiento, se ha exagerado. Entonces, se estrecha y empieza a faltar fuerza. ¿Cómo podemos saberlo? El método diagnóstico es la resonancia magnética de columna cervical, de preferencia si es que son los brazos y las piernas que se afectan, y lumbar si es que solamente son las piernas. ¿Qué es lo que pasa con las personas? Normalmente tienen primero encorvarse, segundo, los pies para caminar los empiezan a hinchar. Ya no caminas con los pies así, sino empiezas a caminar con los pies así, porque tienes tendencia a caer. Y lo segundo es que en estas zonas que tenemos los músculos nosotros aquí, se empieza a hacer hondo, se empieza como a atrofiar, ¿no? Se hace algo así. ¿Entiendes? Como si se hiciera, en vez de lo que nosotros lo tenemos todo gordito, todos naturalmente, porque como está afectándose a nivel del entonces de las dos manos, esto empieza a bajar y se hace como flaco. Está bien, uno puede estar delgado, está bien, puede haber eso, pero que esto se baje mucho, eso no es habitual. O que tenga dificultad para abotonarse, dificultad para peinarse, se le caigan las cosas de la mano. ¿Qué significa? Que la médula a este nivel se está complicando en exceso de lo normal. Una cosa es aceptable y una cosa es en exceso. Entonces, en las piernas, ahora los brazos y las piernas duelen. Y duelen por culpa de estos estrechamientos, de estos desgastes, de estos pensamientos que se forman de forma natural en el cuerpo por culpa del envejecimiento, de la artrosis del cuerpo. Entonces, estas molestias, la única forma de diagnosticarlas es con la resonancia.
La inactividad también colabora un poco.
Ahora, recordemos que lo que protege al cuerpo, o sea, ¿qué hace que mi rodilla no se gaste, que mi cadera no se gaste, que mi cuello no se gaste, que mi lumbar no se gaste tan rápido? Es el músculo. Si uno no se mueve tanto, los músculos se tienden a atrofiar, deja de proteger a la columna, deja de proteger a la cadera, a la rodilla, y empiezan los dolores de cadera, de rodilla, de columna. Entonces, es natural que una persona que no está en movimiento empiece a sentirse mal. ¿Por qué? Porque los músculos se han atrofiado y no hay quien proteja, y empiezan los
Una
dolores.
consecuencia de todo.
Empiezan los dolores lumbares, empiezan los dolores cervicales. ¿Qué hago yo? 2 cosas. 3 cosas. Uno, sí pide examen. La resonancia cervical es para mí un estudio clave para poder explicar lo que siento, lo que veo. Segundo, doy tratamiento con pastillas, relajantes y analgésicos leves, porque no necesito tratar mucho, me trataré algo de forma larga, y voy a tratar con medicamentos leves. Tercero, terapia física. Hay que hacerla sentar, caminar, que se empiece a agarrar de nuevo musculatura, tanto en piernas como en brazos como en espalda. Entonces eso es lo que hay que hacer.
Entonces, la resonancia sería definitivamente.
Para mí es importante para poder explicar lo que estoy teniendo como
para su
sospecha de diagnóstico.
confirmamos.
Lo segundo es que se haga terapia física, que bueno, en este tiempo de pandemia estamos como que limitados, no todos hacen terapia física, no todos lo pueden hacer.
Los
Pero
masajes, rotaciones,
ayuda para disminuir el dolor,
los famosos
pero no para
electrodos,
proteger. Ayuda para bajar el dolor, parece, pero no para fortalecer el músculo. Bien, vamos a empezar con una prescripción médica.
Uno cuando escucha columna piensa que va a volver acá al centro, pero ella lo que le duele es a los lados.
Columna cervical, los músculos de la cervical empiezan aquí en la nuca, van por el medio y de ahí se vuelven hasta los hombros y hasta las 2 omóplatos.
Okay.
Todo es como un rombo.
Ellos hizo una densitometría el año pasado de presentaron osteopenia, que creo que es un paso a la, antes a la, por la edad definitivamente tiene osteoporosis.
Sí, que todas las mujeres en realidad tienen más rápido osteoporosis que los varones.
El dolor es importante, algo para que pueda calmar, ¿no?
Sí. ¿Ella cuánto pesa más o menos?
Y debe estar pesando unos 83 kilos. Tiene gruesa, no es gorda, pero es de, digamos, tiene los huesos grandes, ¿no? Como decir, lo bueno es que una vez por las noches no se despierta, ¿no?
Sí, justo estoy dándole un medicamento para que tome en la noche y otro para que tome en el día. Es con receta. Orfenadrina cada noche, ¿ok? Paracetamol, 2 tabletas después del desayuno, ¿ya? Para que el día esté con el menor dolor posible y que duerma bien en la noche, ¿ya? En cuanto a los estudios que le he pedido para ella, se resonancia magnética cervical, de columna cervical, si encontrar uno de los lugares donde puede hacerse este posición, hay varios lugares. Este tema necesita de medicina física en el caso pueda sé que el salir de casa, consideraciones de que
también le puede ir a alguien a la casa.
por el dolor cervical y de brazo que tiene ella. Mi número telefónico es para cualquier duda por WhatsApp.
Perfecto.
¿Ya?
Queda resultado de la clase que es muy importante.
Sí, me escribe usted para ver qué día estoy, porque estoy normalmente los martes y sábados, solamente el siguiente martes no voy a estar.
Perfecto, doctor. Doctor, muy amable por su atención.
Que le vaya bien.
Muchas gracias.
Hasta luego. Eso.